me. Organophosphate compounds binds irreversibly to acetylcholinesterase in plasma, red cells, and cholinergic nerve endings in central nervous system and peripheral nervous system. Classification of organophosphorus compound. High toxic organophosphates, which are used as agriculture insecticides like parathion, tetraethyl pyrophosphate. Intermediate toxic organophosphate compounds are used as animal insecticides, chlorpyrifos, triclophorus. Low toxic malathion, which are used as field spray and for household applications. Mechanism of action of organophosphorus compounds. They are acid transferring inhibitors of cholinesterase. They cause cholinesterase to become firmly and irreversibly phosphorylated. Cleavage of carbon enzyme bond from acetylcholine is will complete in few seconds. Cleavage of phosphorus enzyme bond takes about 60 minutes to weeks. Reactivation of inhibitor
I think that adjust your mic, ma, Abirami.
spontaneous will depend on species, tissues, and chemical group attached to the enzyme.
Not able to hear. There's a network issue.
Abia, your mic is not working well, Abirami.
Mechanism of action of organophosphorus compounds. They are acid transferring inhibitors of cholinesterase. They cause cholinesterase to become firmly and irreversibly phosphorylated. Cleavage of carbon enzyme bond from acetylcholine will complete in few seconds. Cleavage of phosphorus enzyme bond takes about 60 minutes to weeks. A reactivation of inhibited enzyme occurs spontaneously. A rate of reactivation will depend on species, tissue, and chemical group attached to the enzyme. Reactivation is enhanced by hydrolysis of acid radical enzyme through the use of oximes. Normally, organophosphates attach to estric site and anionic site is free. If organophosphate molecules loses its alkyl group, become resistant to hydrolysis. This process is called aging. The aged phosphorylated enzyme cannot be reactivated by oximes. The pralidoximes have quaternary nitrogen, which attaches to the anionic site. Its oxime end reacts with phosphorus atom attached to the estric site. Oxime phosphonate form diffuses away, leaving the reactivated cholinesterase. The accumulation of acetylcholine causes nicotinic receptors, disturbs the transmission of nerve impulse. Pharmacokinetics. Organophosphates are highly lipid-soluble compounds, so well absorbed from intact skin, oral mucosa membrane, conjunctiva, GIT, and respiratory tract. They are rapidly distributed to all body tissue. They are highly lipids. Their high lipid solubility indicates they can easily cross blood-brain barrier. Highest concentration is usually found in liver and kidney. Metabolism is through oxidation in liver with conjugation followed by ester hydrolysis. Elimination through urine, bile, and fecus. Clinical features. Following exposure to organophosphorus compounds, toxic feature occur within 30 minutes to 3 hours. Most of the patients have accidental or intentional ingestion of organophosphorus compound. Commonest routes of exposure are inhalational, skin, and ingestional. Clinical features are classified into based on time of manifestations, or they are classified into muscarinic and nicotinic effects and central receptor stimulations. Muscarinic effects are mostly 84%. They are more frequent. Includes bradycardia, hypotension, rhinorrhea, bronchoria, bronchospasm, cough, nausea, vomiting, increased salivation, abdominal cramps, diarrhea, fecal incontinence, urinary incontinence, blurring of visions, meiosis, and increased salivations. Nicotinic effects includes tachycardia, hypertension, weakness, cramps, paralysis, and fasciculations. Central receptor effects include anxiety, restlessness, ataxia, seizures, insomnia, tremors, respiratory depression, and circulatory collapse. Um, Cardiac manifestations, most commonly, it includes bradycardia and hypotension. It comprises of three phases. In phase one phase includes prolonged sympathetic tone. Phase two causes prolonged parasympathetic activity leading to AV nodal blockade. Phase three causes QT prolongation followed by TOS HD points VT and VF. Mechanism of cardiovascular toxicity is usually unclear, but include direct toxic effect on myocardium, overactivity of cholinergic and nicotinic receptors, causing hemodynamic instability, hypoxia, acidosis if respiratory system is affected. Respiratory manifestation includes acute poisoning include bronchoria, rhinorrhea, bronchospasm, laryngeal spasm like that. Neurological manifestations classified into three types of paralysis. Type 1, it includes acute paralysis. Initial cholinergic phase, both nicotinic and muscarinic receptors are occupied by acetylcholine, which leads to persistent depolarization and neuromuscular junction. In case of type 2 paralysis or intermediate syndrome, it develops 24 to 96 hours after poisoning. It includes proximal muscle weakness, inability to lift head from pillows, weakness in neck flexion and all. In case of type 3 paralysis, organophosphate induced delayed polyneuropathy, the sensory motor distal axonopathy. Management, it includes, in case of acute poisoning, ABC approach, oral skin decontamination, airway protection if indicated, gastric lavage in conscious patient, activated charcoal, 0.5 to 1 gram per kg every 4 hours. Anticholinesterase, atropine and glycopyrrolate, cholinesterase reactivator pralidoxime, ventilatory support, inotropic support, and feeding enteral or parental route. In case of decontamination, patient removed from the site of exposure and clothes are removed. Patient's body washed with soap and water to prevent absorption through skin. Staff should protect themselves from OPC by wearing gloves, gowns, and eye protector. Gastric emptying should be done if patient presses within 1 hour of ingestion. Gastric lavage means emptying the stomach in unconscious patient after airway protection. Activated charcoal every 4 hours to promote absorption in GIT. Then anticholinergic, atropine. It antagonizes the muscarinic effect of OPC. Then 2 mg IV bolus every 5 to 15 minutes. 2 to 5 mg should be administered until atropinization is achieved. Or continuous infusion, 0.02 to 0.08 mg per kg per hour. Signs of adequate atropinization includes tachycardia more than 100 to 110 beats per minute, moderately dilated pupil, reduction in bowel sounds, dry mouth, and decrease in bronchial secretions. Atropine do not reverse the skeletal muscle effects. Glycopyrrole can also be given for central nervous system side effects. Only few central nervous system side effects. Cholinesterase reactivator, oximes. Oximes are nucleophilic agents, reactivate phosphorylated acetylcholinesterase. Pyridoxine, it has three main actions. Direct reactions converting organophosphate to harmless compounds. Reactivation of inhibited alkyl phosphorylated enzyme to free active unit. Transient reaction protecting enzyme from further inhibitions. Reactivating actions of pralidoxime is marked at nicotinic skeletal muscle and neuromuscular junction. Does not reverse muscarinic manifestations. Dose includes 1 gram IV every 6 to 12 hours in adult. In case of children, 25 to 30 mg per kg. Maximum dose is 12 gram per 24 hours. Effective plasma concentration will be 4 milligram per liter. Show signs of improvement around 10 to 40 minutes after administrations. That's it, sir.
So, any recent advancements in the treatment of OPCP, you know?
Diazepam for seizure control, sodium bicarbonate, gazicyclidine, this anti-glutamagic compound.
Okay. So sometimes questions are worded like that also. discuss the treatment of organophosphorus compound poisoning, including the recent trends in the treatment. So that
Okay,
also
sir.
is part of that. Where did you get this answer from?
Sir, WFAC update analysis.
Case analysis. So this is more or less a topic which I earlier discussed for the senior batches.